other volunteers who have made the Dockside chat a reality. Katie Tomberlin, the chair of the Carteret County Democratic Party, Maria Zempo, Amy Voorhees, and Wendy Boss. A bit of technical housekeeping. All guests will be muted during the presentation. Please check the chat box at the bottom of your screen to find contact information for scheduling vaccines in Carteret County. If you would like to pose a question to one of our speakers, please write into the chat box. Wendy Boss will collate and organize the questions from there. We are very fortunate to have two distinguished speakers this evening, and I'd like to introduce both of them before we get started. Jocelyn Farmer is here tonight from Boston. Jocelyn has her MD and PhD. Dr. Farmer is an allergist and immunologist who specializes in the clinical care of patients with conditions of primary and secondary immune dysregulation. Her training includes a BS from Wake Forest University, an MD, PhD from the University of Michigan, an internal medicine residency, and subspecialty fellowship training in allergy and immunology at Massachusetts General Hospital, MGH, and a postdoctoral research fellowship at the Reagan Institute of MGH, MIT, and Harvard. Following this training, she joined the Harvard Medical School faculty as an instructor in medicine. She co-established and now leads a research consortium for patients with conditions of immune dysregulation at MGH. This has led to her study of patients with COVID-19 during acute illness. Her work has importantly demonstrated critical immune cell changes that occur during active infection with COVID-19 and convalescence. These findings were published in the scholarly journal Cell in 2020, and I add that Dr. Farmer has published widely. Welcome tonight, Dr. Farmer. Thank you for being here with us. Mary Kay Lawrence, MD, attended medical school at George Washington University School of Medicine, completed her fellowship at UNC Chapel Hill, and her residency at Vanderbilt University Hospitals. She is certified by the American Board of Internal Medicine in endocrinology and metabolism. She practices at the Carteret Medical Group and was chosen as the Physician of the Year at Carteret Healthcare in 2018. Dr. Lawrence also founded and serves as the medical director of the Broad Street Clinic, a free health clinic serving adult residents of Carteret County and the surrounding area. Dr. Lawrence's areas of focus are diabetes, thyroid disease, and the detection, prevention, and treatment of osteoporosis. She has conducted studies on a veritable alphabet of medications approved for the treatment of diabetes. Most recently, Dr. Lawrence donated a minus 80-degree lab freezer to the Carteret County Health Department that holds 8,000 vaccine vials, which, importantly, made it possible for the county to receive the Pfizer vaccine that I and many others here have probably already received. With that, we welcome and also thank you very much, Dr. Lawrence, for being here with us tonight. I would like to turn the meeting over now to Dr. Farmer to hear what she has learned about the coronavirus treatment and vaccines in the frozen Northeast. Thank you, Dr. Farmer.
Thank you so much for having me. So I'm thrilled to be here this evening. I do hold a couple industry grants, but none in relation to this lecture. So I wanted to start this evening by talking about what we know about the COVID-19 virus, because I think this is going to set up pretty nicely for an understanding of how we were able to develop a vaccine for this virus. So I wanted to highlight that coronaviruses are actually really common. And so all of you, I suspect, on this call this evening have been infected with a coronavirus, maybe multiple times in the past. And this is because coronaviruses cause upwards of 30% of the common colds that we see every year. In addition, coronaviruses actually have caused previous worldwide pandemics, and there are two in particular that I want to highlight. So the first is known as SARS, or severe acute respiratory syndrome, and this was right around 2000. And then just a decade later, we get another outbreak. This one is known as MERS, or Middle East Respiratory Syndrome. However, the difference from COVID-19 that we're seeing currently to these previous, which I'm showing you in red, is that there were single thousands of cases for both SARS and MERS. And in stark comparison with COVID-19, we're at 100 million cases. And this was really due to a change in transmissibility, or the ability of the virus to move from one host to the next, from SARS and MERS as compared to COVID-19. So how then is SARS-CoV-2, that's the virus that causes COVID-19, able to be so transmissible? And epidemiologic data has shown that it's actually due to the fact that this virus is able to be spread before we have acute symptoms. So what does that mean in practical terms? Well, it means that I'm feeling well. I don't yet have symptoms of COVID-19, but I'm able to shed high amounts of virus out in the community going about my daily business. And especially early on in the pandemic, before we were using the appropriate protective measures, this facilitated this really catastrophic worldwide pandemic. Now, again, as of today, over 100 million cases, including 2.5 million deaths from COVID-19. So what does the SARS-CoV-2 virus look like? So in 3 dimensions shown here on the left, it's really a tight ball, and then what you're going to see in red are those spike proteins kind of coming right off the surface of the virus. And in cross-section on the right, what you see inside that tight ball is the genetic RNA material of the virus. And what that is really the blueprint for the virus, how it's going to replicate and make more and more of itself. And all the rest of the virus is just fancy packaging for that blueprint, okay? So all of the rest of the virus is just how it's going to get from host to host. And right away, researchers became really interested in the spike protein as a potential vaccine target, and this is for a couple of different reasons. And first is the structure. It sticks out quite a bit of distance from the surface of the virus. And that suggested that the immune system might be able to actually bind to it. And in a couple slides, I'll show you an antibody, but an antibody needs some surface to bind, okay? The second component was that the spike protein wasn't changing very much as the virus replicated. So it was what we call conserved. And this means that the virus really wanted to keep that spike protein the same, and it was really important to the virus to keep that spike protein. So we thought, okay, if we can interfere with this spike protein, that might be a good target. And the third reason is that the spike protein is what actually facilitates SARS-CoV-2 binding to us, to our lung epithelial cell. And that's what I'm going to show you on the next slide. All right. So here again is this SARS-CoV-2 virus, and in red again, the spike protein. And what I'm showing you here is that spike protein binding to a receptor on our own cells. And that receptor is called ACE2. And that receptor is expressed at really high levels. There's an abundance of it on the cells that line our lungs. And so this is why this is most commonly the initial site of infection for SARS-CoV-2. Now, if it can bind to cells in the lungs, it makes sense that most commonly we see the disease presenting as pneumonia or lung infection and leading to acute respiratory distress or lack of oxygen, enough oxygen getting to the body. Now on the left, I'm showing you a nice, normal, healthy lung, hopefully what folks in this audience look like at baseline today, okay? And it's really important for the lung to have these nice open airways and these thin, very thin linings. And that's because you want to pull oxygen out of that airway and into the body. In stark contrast on the right, you can see the lung in the context of COVID-19 pneumonia, and this is vastly different, right? So we have this dense inflammation, this dense infiltrate in the lung lining as compared to over here. And imagine how difficult then it would be to pull out oxygen from the airway and to get it to these cells, all right? And so unfortunately, what we see clinically is a lot of patients who are having low oxygen levels and passing away really from low oxygen levels. As well, either in the media or if you yourself had a COVID-19 infection, you might have other symptoms. So some individuals have gut symptoms like nausea, vomiting, diarrhea. Other individuals might have a loss of sense of smell. And this is because other cell types do in fact have ACE2 receptors, just not as many of them. And so that can include cells of the gut, as well as these olfactory neurons, and that controls your sense of smell up in the nose. The next thing I wanted to highlight is who's most at risk for severe COVID-19. As Sue mentioned, a lot of you may have been eligible for your vaccines already. So why was this the case? Why did we target you all for vaccines early? So early on during the COVID-19 pandemic, and these are data from the NIH, we understood that as you age, so I'm showing you increased age here on the x-axis, your risk of being hospitalized from COVID-19 infection goes up, particularly over 65, 75, and then 85. And while this is showing hospitalization from COVID-19, the death from COVID-19 closely follow the same trend. As well, during COVID-19, we've come to understand that all races are not the same, okay? And in particular, we've seen deaths here from COVID-19 at an over 2-to-1 ratio comparing our Black or African American citizens in the US to our white US citizens. And this has been an unfortunate trend that's continued throughout the course of the pandemic. And finally, we know that risk for severe disease correlates with comorbidities, particularly obesity, defined as a body mass index over 30, diabetes, chronic obstructive pulmonary disease or COPD, heart disease, and chronic kidney disease. And unfortunately, in the US, when you add up all of these comorbidities, this constitutes about 40% of our adult population, meaning we were at very high risk for severe COVID-19 when this pandemic hit. Okay, so that's all the negative of how the virus affects us. What about the immune system? What is it doing from its side to combat this virus? So there are two arms of the immune response that are really critical in defense against SARS-CoV-2. The first important cell is called a B cell. This cell makes antibodies, and those antibodies end up in your blood, and they can bind to viruses that they recognize and mop up that free virus before it has a chance to even get to that lung epithelial cell, okay? So playing a fantastic role early on in infection. Even if the virus makes it all the way to that lung cell, the next line defenders are called T cells, and our killer T cells are like our snipers of the immune system. They come along and they look to recognize a virally infected cell and then eliminate it in a very discrete fashion so that they don't cause a lot of inflammation. So B cells making antibodies, mopping up free virus, and T cells coming along and taking out the virus that's hiding inside cells. And both are very important. So how about herd immunity from COVID-19? This might be something you heard about in the media. And so initially when COVID-19 hit, unfortunately, as a community, we did not have protection against COVID-19, and we were susceptible, as demonstrated here in blue. And when the virus hit, this led to a high level of transmission. And so a dense population got infected all at once. And these infected individuals I'm showing you here in red. And this really overwhelmed our healthcare system. The optimistic hope for a long time was that from natural infection, we would develop immunity, and this would make us protected against a subsequent infection with SARS-CoV-2. And that's shown here in these green individuals, such that if the same amount of virus stayed in our community, now we transition from a high transmission state to a low transmission state. We have lower number of infected individuals and less strain on our healthcare community, and life can go back to normal. However, this really wasn't what we saw as the coronavirus pandemic continued. And it made us wonder why we weren't mounting an appropriate immune response naturally to this virus. So it turns out that SARS-CoV-2 is a bit tricky. When we get infected with this virus, it actually damages our immune system to some extent, such that we can initially make those protective antibodies to the virus, but they don't hang around, okay? So after a couple weeks, those antibodies have gone back to normal, and this sets up for a scenario where you can get a reinfection with SARS-CoV-2, and we've seen certain cases of that come out in the press. So our lab was really interested in understanding why we weren't maintaining these protective antibodies. And so we looked at the part of the body where we educate the immune system, and that's called the lymph node. And what I'm showing you here are B cells in this nice green color and T cells in this nice red color. And this is a normal response to infection. And see this beautiful architecture here? The B cells stay in their area, the T cells stay in their area, everyone's organized. And this allows the B and T cells to talk to each other, and for the T cells to really educate the B cell how to make that antibody, how to make a long-lasting and good antibody response. In stark contrast to this, we saw in severe COVID-19 patients, these were unfortunately patients who'd passed away from COVID-19, there was just total disorganization of this lymph node structure. The T cells could no longer communicate with the B cells, and we lost that long-lasting protective antibody response. Okay, so that's natural infection. What about vaccination? Is that going to be the same, or is that going to be different? And fortunately, so far, it looks like it's going to be much different. So here I'm showing you vaccination. Following vaccination, it's already been shown that you can make a beautiful antibody response to the mRNA's vaccines. That's going to be specific to the spike protein. And then over time, at least out until 4 months, I'm going to show you that data in a second, you're able to maintain that antibody response, and it's not waning over time. And this I'm showing you for the Moderna vaccine, but similar data have come out for the Pfizer vaccine. The arrows are indicating when the study participants were immunized. And here you see that nice antibody response coming up and sustaining. And it's sustained even for the 50 to 70 and greater than 70 age ranges, which is outstanding. So we know that following vaccination, immune protection is going to be longer lived than naturally acquired infection. How long? We're not yet sure. Okay, so I've just told you that a vaccine can give you a longer lived antibody response than naturally acquired infection. What are overall your risks and benefits, though, of the vaccine? So because it was so important to create a vaccine that was going to be successful to SARS-CoV-2, multiple different strategies were tried in parallel. And really, the mRNAs have come to the forefront as the winners. So the Moderna and Pfizer, they were the first out to show clinical success and clinical efficacy in their phase 3 trials. And those are the two that are FDA approved for use in the US. However, some of the additional strategies, and these are actually pretty similar strategies, the mRNA and the actual DNA vaccines, where they take that genetic material I told you about, specific for the spike protein. And the difference is the mRNA vaccines package that mRNA in an artificial lipid, basically a fat membrane. And in contrast, the DNA vaccines, that's going to be AstraZeneca and the newly completed Johnson Janssen vaccine, they use an adenoviral vector to kind of deliver that genetic material. There are other strategies still in the pipeline, for example, taking off that spike protein and presenting that to the immune system, or inactivating kind of a natural form of SARS-CoV-2. However, these are still in clinical trial. So the Moderna, the Pfizer, and potentially the AstraZeneca and the Janssen are the ones that are kind of coming to the forefront as those available in the US. Okay, so how about the 2 FDA-approved vaccines that are already out? How did they show efficacy? So to show vaccine efficacy, they had to run a clinical trial, and the major outcome is more COVID cases in placebo group than vaccine group. It's that easy. So in the lay press, you may hear about mild COVID cases, moderate, severe COVID cases, but overall, when they tell you their overall efficacy, that's number of total COVID cases in the placebo group compared to the vaccine group. And the efficacy of both of these vaccines was absolutely outstanding, 94%. They have a slight difference in how much mRNA they present. They do have an inactive ingredient, so we're going to talk about vaccine allergy in a second, and both of them do contain PEG 2000 or polyethylene glycol as a stabilizing agent. The dosing schedule is a slight bit different. So the Pfizer you get is 2 doses 21 days apart. The Moderna you get is 2 doses 28 days apart. And the storage is slightly different. So the Pfizer has to be stored at a colder temperature to accommodate a slight difference in how they made those fat membranes. And they do have both local and systemic side effects. And those are actually pretty similar in spectrum. So what local symptoms should you expect when you get immunized? And so I would say everyone should basically expect local symptoms when they get immunized. So 80 to 90% of us will get at least one local symptom: swelling, itching, redness, or pain. And with these vaccines, we have been seeing about 10% of individuals who will maintain kind of a red swollen area up towards a week or two post that vaccination. It is not an immediate allergic reaction, and it is not concerning for not being able to receive a subsequent immunization. You can use cold or heat to that site. You can even use something like a topical steroid should you need to that site. You can take things like over-the-counter Tylenol, or Motrin is needed for pain control. But even a local reaction, as I'm showing you here, would not prohibit you from receiving your second immunization. How about systemic symptoms? And so I'm showing you here data from the Moderna trial, although it was very similar to the Pfizer trial. I'm showing you here any systemic adverse reaction, and these are the percentage of patients who develop that. The first two bars are the first and second dose of placebo, and the next two bars, the first and second dose of that mRNA vaccine. And what you can see with the second dose, as compared to the first dose, that there was both an increase in total symptoms as well as an increase in grade 2 and 3 symptoms with that second immunization. That's not surprising. You have a first dose and then a boost. And with that boost, your immune system's really remembering that it saw that immunization previously. And so fever, chills, headaches, muscle aches, joint pains, even some nausea and vomiting have been reported. And overall, again, you want to expect to have these symptoms, as the majority of people are going to have at least one of those symptoms, again, increasing with that second dose of the immunization. Again, however, there's no increased risk of an allergic reaction. These are symptoms of immune activation, so kind of an expected side effect of an immunization, and you can certainly receive your second dose. So then how about these severe allergic reactions which are in the press? So in the UK, Pfizer vaccine was approved in early December, and a short 2 days later, this comes out with 2 individuals who did have a severe allergic reaction following immunization. What are they actually reacting to? So in a vaccine, we have what's called both the antigen, that's the actual mRNA that's triggering the immune response to COVID, and we have additional components known as excipients, and those are components of the vaccine that are helping to stabilize it or a part of how it's made, okay? And in these vaccines, they both have that PEG 2000 or polyethylene glycol that's specifically used to kind of keep that membrane layer around the mRNA intact. So the lay press has a lot about these allergic reactions. Should you really be concerned? So of around 2 million doses of the Pfizer vaccine that was administered, there were only 21 cases reported as of this month for severe allergic allergy, and we call that anaphylaxis. So that leads to about 11 cases per million doses of the vaccine. Let me put that in perspective for you. So this is increasing frequency of severe allergies. And here's intravenous penicillin, the Pfizer COVID vaccine, IV contrast that you get routinely for something like a CT scan of the chest, and IV penicillins. So if you feel comfortable taking on the risk of something like an IV contrast for a chest imaging scan, the risk of the COVID Pfizer vaccine is much lower than that, okay? And so really the CDC has come out and said, this is a very small acceptable risk. So how do we screen out then those individuals who might be at highest risk for these allergies? And initially in the lay press, there was kind of this label that came onto the vaccine saying, anyone with severe allergies, beware. And so as allergists, we've had to go step folks back from that a little bit. okay? So if you've had an allergy to any oral medication, if you have a history of food allergies, pet allergies, insect, venom, environmental, latex allergies, we are not worried about you with this vaccine. Family history of allergies, similar. We are not worried about you with this vaccine, and you can go ahead and receive it. And really the only individuals who need to take caution is if you've had a severe, really at the level of life-threatening allergic reaction to an injectable, an IV medication, or a vaccine previously. And in that case, you're going to do an additional risk assessment with a doctor. And what they're going to do in that risk assessment is to see if there are any shared components between the medication you reacted to and the mRNA vaccines. And if there are no shared components, they're still going to recommend that you go ahead with the immunization. And only in the context where there's a clear shared ingredient are they going to recommend a pause. And in some cases at NGH, we're doing skin testing specifically for that PEG to see if you could be allergic. So then how well are we doing with this vaccine rollout? So Israel, the UAE are clearly leading the way. They have the majority now of their population who've at least completed the first dose. However, the US is not so bad. And as of today, we're around 16% of our population that's at least received the first dose, which I think is very optimistic. And then our remaining questions are really, will this vaccination protect against the new SARS-CoV-2 variants that are coming out? So I'm sure many of you have heard about this UK variant, now the South African variant and the Brazil variant. What these are genetic changes over time in the virus, such that it's changing how that spike protein looks. And again, because our antibodies recognize the spike protein, this will change the efficacy of the immunizations to some extent. The good news is that we're starting with outstanding, really over and above what we all expected or hoped for, efficacy at baseline at that 95%. So even a small drop with a change in the spike protein will still likely yield that herd immunity in the figure we demonstrated before, but those data are still coming. Okay, and then our final question is really, is immunization going to change our lives, right? We're all on Zoom meeting tonight. We want to get back to life. We want to have our Dockside chats again. And really, we want to change our non-immune status to this immune status, where we have fewer people in our population who are susceptible to the virus, and we have this low transmission state. And so to date, what's really been shown with the immunizations is that the immunization is protective for the person who received it. So you're not going to develop symptoms, even should you be exposed to the virus. But what we haven't demonstrated yet at a population level is that that reduces passing on the virus to the next individual. We do want to continue to watch case rates, and they are falling in Israel, in Europe, and in the US as well. But we want to take a little bit of pause with these data because it still is early into the immunizations, and countries like South Africa, where immunizations really haven't even started to begin yet, are still seeing a drop in case numbers. And so this may be just the natural evolution coming off of kind of that Christmas explosion of cases, or it could be the efficacy of the vaccines kicking in, and that's yet to be determined. And finally, I wanted to end with what you do after receiving your immunization. So you get your first dose, go ahead and get that second dose. Again, 95% efficacy has really been demonstrated following a week after your second dose. So after your first dose, you want to behave like you really haven't been immunized, and you want to wait for that second dose to get to your 95% efficacy about a week after that second dose. Regardless, even after that second dose, for right now at least, you want to continue to wear a mask, wash your hands, and perform social distancing. And again, that gets back to transmissibility, okay? So what's really, again, been shown is that the vaccine is beneficial to the person who's received it. What we need to see at a more global scale, and at first really a national scale, is that we're reducing number of cases in our communities. And at that point, we might be able to change some of these guidelines, but for right now, they absolutely stand. And these are the additional data. Again, they'll be put in the chat. This is a fantastic lecture from MIT, which I really encourage any and all of you to go to for additional information about this virus. And then the response to the allergic components of the COVID vaccine is really an active pursuit at MGH in the allergy immunology division. So we're keeping active tabs on that as we immunize first our employees and next our patient population. And with that, I'll stop sharing my slide and take any questions I think we may do at the end versus in the middle.
Yes, thank you so much, Dr. Farmer. That was thorough and very accessible. Really appreciate that very much. Let me remind participants to please add questions to the chat box, and we will address them after we hear from Dr. Mary Lawrence. Dr. Lawrence, please bring us up to date on the virus in Carteret County. How are we faring, and what do we need to know?
So I will start out by mentioning that we tried to reach out to someone to the health department to be involved with this meeting tonight, and they were not available. So I am filling in on their behalf. Happily, Dr. Vicki Morris is also on the call. She's our infectious disease expert at Carteret Healthcare. So she can correct me if I say anything wrong. And she's also a great resource for questions regarding local issues with COVID. The reason I really got involved with COVID-19 is that I do clinical trials with Lilly, the big insulin company, and since I do diabetes, they reached out to us in September and asked if we wanted to do trials with their monoclonal antibodies, which are used as treatment. Not to be confused with vaccination, but for treatment for people that had an active COVID infection. So we enrolled our first patients in early October. To date, we've enrolled about 20 patients in clinical trials for Lilly. And as a result of getting experience with the monoclonal antibodies, we were able to get the emergency use authorization for the antibodies at Carteret Healthcare. So for those of you that are not familiar, this is a treatment that has been developed by a couple of companies, one being Lilly and the other one being Regeneron. And since this is a group, so we are enrolling in clinical trials currently, but happily, the monoclonal antibodies are available through our hospital for people with symptoms of COVID-19 and with risk factors. So the risk factors being age over 65, or anyone with over 18 who has type 2 diabetes, obesity, lung disease, hypertension, so the same risk factors that Dr. Farmer mentioned. So we have done to date, I believe, around 180 infusions of monoclonal antibodies in our small little community hospital. And our hope is that these outpatient treatments prevent people from becoming inpatients and becoming more ill with COVID and ending up with pneumonia. So the rationale for treatment with patients with mild to moderate symptoms is to prevent progression onto a more serious disease. So we'd like to think that we've been able to prevent some cases locally of becoming more advanced. I looked at the numbers today, I believe 4,700 patients have had COVID-19 in our county. We've had about 45 deaths. Right now, I think we only have 6 to 8 people in the hospital at Carteret Healthcare with COVID pneumonia, and I believe there's about 140 active cases in the county. So that is a vast improvement from what we were seeing 2 or 3 weeks ago when we had that terrible spike after the Christmas and New Year's holidays. I think we're yet to see if there's going to be a spike after Super Bowl Sunday, but so far we're not seeing that. And as Dr. Farmer pointed out, the numbers across the globe, even where they don't celebrate Super Bowl Sunday, are going down. So I'm taking that as very good news. The vaccine availability, and Dr. Morris may be able to speak on this more if there's questions about it. We were getting lots of vaccines in December and January. Our numbers of what we're receiving from the state have decreased probably in half. So there are still a number of people wanting vaccines that are not able to get them. There's a long waiting list. You're being told now there's at least a month's waiting list, but I talked to patients today that have been on a waiting list for 5 to 6 weeks and they still haven't gotten called. So this is a concern. But I think we're all just trying to preach patience. The vaccines should be increasing over time, and we are really trying to vaccinate the most vulnerable. So patients in nursing homes and assisted living have almost all been vaccinated, the ones that wanted it. And I believe our numbers here are at least 80% of patients in nursing homes wanted the vaccine, or their family wanted it for them. Unfortunately, only about 30 to 40% of workers in those facilities have been vaccinated, but I do think our numbers are increasing as people see more results that we're not growing a third arm, and the people that have been vaccinated seem to be healthy, tolerating it well with the known reaction that you get, the systemic symptoms that you can get. So we are getting the most vulnerable. Certainly frontline workers who want the vaccine have been able to get it. We started with the over 75. I think once we opened it to the 65 to 75 in a retirement community, that greatly increased the numbers of people wanting vaccines. And as you all have read, the county has now is now renting the Kmart, the former Kmart space for vaccinations. There will be one more this weekend at Newport Elementary School, which is going to be a second vaccine clinic. But going forward, almost all of the ones that are not at the hospital or at the health department will be at Kmart. So, and that seems to be going well. I've spoken with people who've been vaccinated there and are pleased that it's been as smooth and gone as well as they had hoped. If you know people that are TRICARE, so retired military, those people and their spouses can be immunized on the base. I know at Lejeune, and I presume at Cherry Point, but definitely at Lejeune. I think there's, you just call, I don't think there's any specific appointments, so they seem to have vaccines there. And then you've probably heard that the Walgreens are going to be getting vaccines, or have been getting them as of this week. Only about 100 vaccines per week. So I don't think it's going to make a big dent. And that's only online registration for those slots. Broad Street Clinic has been able to obtain a -80 freezer with the help of Duke Marine Lab and the Duke faculty. So that's now in place. We would like to get vaccine at Broad Street specifically for more underserved communities. But right now we are just getting some vaccines from the hospital that they're sharing with us to try to get some of our underserved population. And that is about all. I wanted to leave lots of time for questions for Dr. Farmer, and Dr. Morris is also on the line. And I'm happy to answer any questions as well. And thank you to Dr. Farmer for that great presentation.
And I think there are two questions to me, or I think there's direct message questions to me, but maybe if it's okay with everyone, I can read them to the group. Would that be okay? Okay, so
Right ahead.
The first one says, do you recommend for someone who has high immunoglobulin numbers, I'm thinking you're meaning your IgE, your allergy antibody level, and high allergy to many medicines in the past, should I go ahead with a Moderna or Pfizer, or am I someone who should wait for kind of these Johnson or other vaccines to come out? So actually the IgE level I feel 100% fine with. That level is elevated with someone with seasonal allergies, for example, and would have no risk to receiving either of those immunizations. And then the high allergy to multiple medications in the past, I will tell you, I've done vaccine allergy clinic now for a couple of months, and most often, even with a really full panel of allergies, most of those are going to be oral allergies, just because most of us get oral medications, right? So very few of those allergies are going to be to an IV medication or a previous vaccine. However, if those allergies are to a previous IV medication, for example, that you were given in the hospital through a line that was placed, or to a vaccine, then in that case, yes, I would recommend that you reach out to your primary care and ask to see if they can do kind of a risk assessment for you, or if they can refer you to an allergist to do a risk assessment for you. And then they may recommend going forward with the immunization or not. but with a long list of allergies to things like environmental allergies, like dust, pollen, mold, that has no issue, to latex, no issue, to food allergies, no issue with these immunizations, and to most medication allergies that I have gone through with patients, there's no issue. I will also say that the Pfizer has a close relative of the PEG in it. So if you're holding your breath and thinking, I'm going to go ahead with the Johnson & Johnson, it may be okay, it may not. So in folks where we've seen anaphylaxis, a severe allergy from the Pfizer or Moderna, we actually skin test to that family member of the Johnson & Johnson and AstraZeneca to see if you might be a candidate for those alternatively. But certainly I wouldn't hold my breath and kind of say I'm empirically going to get one of those other vaccines. The same issue will come up with those other immunizations, okay? So I think the right thing to do is just to have a visit with your primary care, say, you know, either I went to this lecture or I heard on the media that, you know, there are, you know, kind of severe allergic reactions. Am I someone who you would worry about? But your IgE level, no problem, I'm not worried. And if it's a list of oral medications, environmental allergies, food allergies, I would have no issue with that. And then the other question, I think, was, after receiving my first dose, when can you expect those systemic symptoms? Great question. So as soon as 12 hours, and usually lasting up until 48 hours after the immunization, or when most people are experiencing those symptoms, it is totally reasonable to go into your immunization on things like Tylenol, ibuprofen, whatever you have in the house that has worked for you previously. If you're someone who's really prone to things like joint pains or muscle aches with other immunizations, I would just expect them with this immunization, okay? So instead of waiting for them to occur, it is absolutely fine to take things like an ibuprofen or a Tylenol to kind of get you through these immunizations. So I think anticipating those side effects and not, they're a little bit less worrisome, right, when you're going into it expecting this to happen rather than it kind of happening on the back end. And then one other one, I came late into the meeting. Am I correct to understand that the second dose of Pfizer is the same vaccine and acts as a booster? You're absolutely correct. So the dose is actually identical, but it's the second round your immune system has seen it, and the immune system's smart. So the first time the immune system sees it, it makes the antibodies and the T cells, and then the second time it says, ooh, I've seen that before, and it can boost them up to a gorgeous level. And so it does act as a booster. So the first dose, it's about 50% efficacious 2 weeks following the first immunization. We don't know how long that lasts because the group got re-immunized with the second dose, okay? So the UK is kind of doing the experiment, right? They're if you've been reading the news on them, they've decided we're gonna go ahead with the first dose and immunize more individuals in our population and then extend out into the second immunization. We don't know how that's going to work. In the US, we're really going off of the phase 3 trial. So we're going exactly according to the protocol where we know the efficacy at each time point. So we're doing the first immunization and then 3 or 4 weeks later, depending if you get the Pfizer versus the Moderna, you come back for your booster dose. And then that's what gets you to that 94, 95% efficacy about 1 week after your second dose. So after your first dose, I would act like you have not been immunized because it's about 50%. And for the folks on this call, when you break that down by age, unfortunately, it favors the younger people in the community for that 50%, okay? So you just want to assume with your first dose that you basically did not receive it. You get up to that 95%-ish about a week after your second immunization.
Very good. Thank you so much. Wendy, do you have more questions?
We do. We have several questions for Dr. Farmer. Can someone with non-Hodgkin's lymphoma get vaccinated?
Yeah, great question. I would highly recommend it. Yes, you can. And so I actually treat patients with no immune system. So I treat patients with no B cells, with no T cells, and we've gone ahead with immunization with both Pfizer and Moderna vaccines. So you're at higher risk, right, with lymphoma if you should have the natural infection. And so the risk in you is that you may not boost to the same protective level as the rest of the community. So we received approval at MGH to actually test for that in my patients. It's not something the CDC wants to do at a global scale. It may be something your hematologist, oncologist would support. And you'd have to have a test that would allow you to detect for that spike protein. Some of the antibodies out there are for other parts of the virus, and you're only making antibody when you've been vaccinated against the spike protein. So it's a little complicated, but there are ways to try to test to see if you've mounted an adequate antibody response. But yes, I would highly recommend that you go ahead with the immunization. And the ability of your, how effective it will be in you is actually dependent on how well controlled your lymphoma is. So if you're on active chemotherapy versus not, if you're, if that non-Hodgkin's clone is suppressing your other immune cells or not. So the more controlled your lymphoma is, the better of a response you're going to get to that immunization.
Thank you. I think you addressed this to some effect. Is the vaccine less effective with age after you've had the 2 dosage?
Yes, yeah, and it is a little bit, okay? So when you break down Moderna by age, when you really get to that high end of age, it drops a little bit to about 86% compared to 95%. So it drops a little bit with age. They also, though, looked at your T cells. So we know as we age, our T cells decline. It's probably why you're more susceptible in later decades, right? It's probably a T cell response. And the T cell boost to this was really outstanding. So for your age demographic, these are outstanding immunizations. And I would highly recommend that. They had great antibody responses. They had great T cell responses, which I think was a really high bar to hit within this age demographic. But yes, as we age in general, our immune system is just not as robust. And so yes, you're going to have slightly lower efficacy as compared to a 20-year-old who gets the same immunization.
What about people with type 1 or type 2 diabetes? Is there a difference, and should they get vaccinated?
Yeah, so I would 100% recommend getting vaccinated with either, and probably we should have the endocrinologist weigh in more strongly than me. But yes, absolutely. So as we mentioned, diabetes falls into that higher risk category. And so absolutely, patients with comorbidities were actually, increasing. Even if you're a younger patient, but you have a comorbidity, a lot of times you're falling into a vaccine priority group because of that complication. So should you develop the naturally acquired infection, we would be more concerned about a severe COVID-19 course. And so that would be an increased indication for you to go ahead and receive that immunization. And I'm not aware of any higher risk from immunization in a patient with diabetes than a patient who does not have diabetes.
Does that conclude the questions, Wendy?
No, Dr. Lawrence, did you want to comment on that?
No, I would agree. And then there's a question about type 1 versus type 2. I would say the risk is probably not very different. Of course, type 2s tend to have more obesity. And so honestly, they might have 2 risk factors, diabetes and obesity. So I think the risk is going to be across the board high for anybody with diabetes. So again, I would echo her remarks that these patients should be high priority for getting vaccinated.
There are a few more questions. Is there, if you've had 2 doses and wait 2 weeks, can you socialize with other people who've had 2 doses 2 weeks after they finished?
That is $1 million question. So I would say right now, what the data show is that if you do that socialization, you're at lower risk of contracting symptoms should you get exposed. But they had documented asymptomatic cases. So it doesn't mean that you can't get the virus, just that you don't get symptoms for the virus. Does that make sense to everybody? So the virus gets in the body, but those antibodies we talked about are mopping it up, and the T cells are coming in quickly and mopping it up. So how quickly that occurs, and then can I transmit virus while I'm clearing it very quickly? That's the data we still don't have. So as of right now, the recommendations per the CDC is that you're continuing with your current lifestyle. Now, I have some patients I care for, particularly my immune deficient patients that haven't left the house in a year, right? So I certainly think it's reasonable to take on some increased risks if you've been very, almost contained and going stir crazy. But I still think, you know, social gatherings, you want to be in a mask, you want to do good hand hygiene, and you want to think about your social distancing still. So those guidances really haven't changed. If the rates come down in our community, and we're seeing, you know, that this trend of decreasing cases holds, if we have data that demonstrate that we can't transmit the virus after we've been vaccinated, and I think once we have more data on how the vaccines handle these variants, that guidance may certainly change. But for just this moment in time, they're still recommending, the CDC is still recommending that after that second immunization, you're still wearing your mask and having social distance.
Can you predict when we might get back to normal?
I honestly would predict this summer. I don't think that's crazy. You know, a lot of my patients have kids out of school, right? And so I think coming into the summer, I really don't think that's crazy. I think we'll have a huge percentage of the US that's been vaccinated, hopefully. And I think how effectively, you know, we're able to have those vaccines administered, and also the how that's being received by the community and the folks that are signing up within the community to be immunized, that's definitely going to determine this. This is not a case, as I went through, that natural immunity is going to get us out of. So it's really going to be directly dependent, I think, on you know, how well we're vaccinating in our community, and also really keeping up those social distancings and letting those caseloads come to basically nothing in our population. So I think it's both raising awareness of vaccination, monitoring how it goes afterwards, but I don't think it's crazy to think this summer might be a different situation.
Great news. Thank you.
Yeah.
So one of our participants, is that Barbara Thomas? Barbara, is that you? Says her daughter is part of a study of SARS-1, MERS, and COVID-19 immunity to cope if people with that immunity, I guess, have resistance to COVID-19.
Yeah, and they're out about it. So it's so there's an individual who does a lot of antibody responses and has been very interested in that. And so there are folks out there in the community who've had some exposure to these prior pandemics, although most of us who have been exposed to the cold, it turns out do not have these protective antibodies. There are some that have gone through previous pandemics that do. It's interesting though, in that the previous pandemics, the antibodies don't stay in everyone. And so it does seem to be something that's coronavirus specific, that they're able to interrupt this interaction again between our B and T cells and get this long-lived immunity. So the magnitude of that in the total population, we don't know. There was also some interesting data coming out to say whether those pre-existing antibodies could actually facilitate entry into cells, whether it was positive or negative to have that pre-existing immunity. But overall, it's a very small percentage of the general population. So we want to think about the population in general being not immune and not having antibody responses at all to natural COVID-19. But it's interesting research data. I agree.
Can I ask a follow-up question?
Please. Yep.
Yeah, it's my daughter. We both had COVID-19. She's part of the study. And they haven't published the results on COVID-19 yet. But they have on SARS and MERS. No, they haven't published it, but they have a preprint on SARS and MERS. They have not announced what they did on COVID-19. Those are, I think they're called alpha coronaviruses, and yeah, which is not the common cold. There was also a COVID-17. It's also in the study. Those are the 4 alpha coronaviruses we know that have gone through the population. I think their assumption was that the spike protein was the same in all of them, and that we might have T cell memory for the spike protein.
Yeah.
That would not have been, I mean, I don't know the results yet, but it sounds like it wouldn't have been undermined by, like COVID-19 undermines immunity, but COVID-15 and 17 were much milder diseases. They were long, I had one, 5 weeks, but they were mild.
Yes, and so they actually can be mild infections. So it's a different context between, you know, symptomatically mild and insult to the immune system. And so these as a group, you know, even the common cold, right? Why can't we get an immunization against the common cold? It's really annoying, right? but we keep getting recurrent courses of the common cold. And so this virus has an ability to inhibit long-lived immunity, even from things like the common cold. So it might symptomatically be a mild infection, but it still we have trouble maintaining long-term immunity to coronaviruses. And so that's an interesting area. But I agree with you, you still have your T cell response. And I think that might be a very prominent feature of individuals who have had prior exposure being able to fight this off.
Very good. Thank you so much. Wendy?
We have one more comment that we have one participant who's had COVID last March and is still feeling fatigued, et cetera. Is that normal?
Yeah, so unfortunately there are what's being called these long haulers coming out from COVID-19. I think it's going to, you know, and Dr. Lawrence can speak to this as well. We haven't had a lot of financial support for patients with things like chronic fatigue, right? I can't tell you how many patients we see with kind of chronic fatigue and these types of issues. I think this is going to transform the field. I think there's going to be a lot of patients who have lingering pulmonary complications, as well as kind of more diffuse complications coming out of this infection, unfortunately. And so we absolutely are seeing that. There is active research to understand kind of the remodeling that happens in the lung. And so initially it's just really cleaning up the virus, but there are individuals who are more or less prone to kind of making scar tissue in the lungs, and how that's affecting the breathing long term. Folks are certainly looking into. I would say we don't know yet enough, but certainly I would imagine that treatments would come subsequent to that research. I'm hopeful that your clinical course will improve such that you won't need to be in part of that group, right? But I do think we are seeing these complications. In terms of still going forward with an immunization, I would still strongly recommend it. So there have been, you know, individual cases of people getting a reinfection. And again, we have this problem with long-lived immunity from naturally acquired infection. So even in folks who have had natural COVID-19, I would certainly still recommend going forward with immunization.
Very good. Thank you so much. I think we're going to do a public service announcement now. But first, Dr. Lawrence and Dr. Farmer, thank you so very, very much for being here. This has been extremely interesting. Dr. Morris just put a website into the chat with information for long haulers, people who have the virus over a long period of time. So it might be worth checking that out. I want to remind everyone that there's information in the chat box about scheduling appointments. It's available at the top of the chat box, also on the website carteretdemocrats.org. That is our website. The party is also sponsoring events to assist anyone who needs help scheduling an appointment. Yolanda Lozano and Jay Reebsale have undertaken to reach out in this way. Thank you very much to both of you for doing that. They will have a table set up at the coffee shop Sweet Beans this week on Thursday morning, February 18th from 9 to 11. After that, they will have a regular schedule, but we're not quite sure what it's going to be, and you can check at Carteret Democrats. Our next Dockside chats, scheduled for March and April, will focus on our schools, our kids, and they will be on the third Tuesday of the month at 7:30, except for March 30th, which happens, interestingly, to be the fifth Tuesday of the month. On March 16th, we will talk about school during the pandemic and beyond. March 30th, keeping great teachers and staff. And on April 20th, we will have an update on school bond spending. Thank you again to our very distinguished guests. And Dr. Morris, thank you so much for joining us. To all of our participants, thank you for taking your time to be with us tonight. And we hope to see you again later at another Dockside chat. Good night.